Hey, good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System. I'm joined on my right by the good and faithful Dr. Dana Hawkinson, Hawkeye, and on my left, Rachael Liesman. Rachael is one of our heroes here in our health system, someone who has worked extraordinarily hard to make sure that our ability to bring testing to you is both true, accurate, and we have enough to be that we can do. We're also joined on the phone, albeit briefly today, by Lee Norman, who's been called to do some important action at the State House. And so we wanted to hear from Lee right up front because he's got some important news. And so, Lee, you're on, I think.
Thank you. I appreciate the invitation. Sorry I can't be in the studio with you, but the Legislature of Kansas is in special session, and I've been asked to testify on the subject of contact tracing, actually. But I did want to talk just briefly about the fact that our Kansas Health and Environment Lab is going through validation processes this week to make available starting next week a COVID-19 specific antibody test. We're testing it, our testing platform, against some paired samples for both of the antibodies that we concern ourselves with, IgM and IgG antibodies. It will initially be a test that's drawn on a blood stick from the arm, that is a sample drawn, but we're looking to also, as some other labs have done around the country, to do a capillary test, which is just a finger stick test, or a blood spot test, which is, again, a finger prick, and put it on blotter paper. So that's good news for us. Now, antibody testing isn't new for the COVID-19, and I bet you'll go into this more deeply in the balance of this show this morning, but there's been a lot of problems out there with the antibody testing that's been done to date because it's not specific for COVID-19. We've even turned this over to the Attorney General because of the state of Kansas, because some places have been offering up what they are advertising as COVID-19 specific antibody test, which is bad enough since it wasn't, saying that it's 100% sensitive and specific, meaning you wouldn't have any false positives or false negatives to speak of. But then the most, I think, kind of concerning thing is that people were said, well, if you're positive for a coronavirus antibody, you don't have to wear PPE. You can take care of people with active COVID-19 disease. And the problem with that is, of course, that people can have the coronavirus, the non-specific, non-COVID-19 coronavirus from the common cold, and the tests that have been available more broadly over these last couple of months have not discerned the COVID-19 from just the common cold. So that was actually both kind of a consumer fraud and also kind of a consumer safety, really, issue. We are going to start using antibody testing in our testing algorithm. The thing that people, I think, have to understand is that the antibody test, at least the current thinking, is that it's not a diagnostic test. A diagnostic test means that you, with a PCR or one of the methods we've talked about in the past, is how you diagnose active disease. The antibody will tell you if you've been exposed to it or have had it, but will not necessarily discern active disease. So where we think it fits in, and this will be subject to debate as time goes on, is where we've, throughout the state of Kansas and really all over the world, that's been mostly a problem, or quite commonly a problem, with congregate settings. And examples would be nursing homes, skilled nursing facilities, meatpacking plants, or like we're seeing here in Topeka at a food processing plant in Topeka, and in prisons and group homes, that kind of thing. So we think that it'll be really helpful to test people for antibody in congregate settings that are residents and staff that spend a lot of time there. And then if people have a positive IgM antibody, to test them and see if even if they're asymptomatic, to then do a diagnostic test, for example, the nasopharyngeal PCR test. A second thing that'll be really helpful, and this is purely from a public health and perspective, is prevalence studies. So you can test a county, we can say, and see what is the prevalence of disease in that particular county, because we know that there's been a lot of undiagnosed both undiagnosed and asymptomatic cases. This has been done in Iceland and some other places, and we just haven't had the capability to do that yet. But prevalence studies will give us a really good idea, especially going forward into the fall and winter, where the disease has been prevalent. And then the third one, and I don't know exactly where we'll go with this, but there's getting more and more evidence that plasma donation of those people that have had the COVID-19 illness and responded, that the COVID-19 antibody testing will be quantitative eventually to help screen out until we have effective treatment and effective vaccine. It could be a valuable adjunct for more broad screening of who are the plasma donors that might assist in treating patients with advanced disease or worsening disease, because there is some early indication from studies that that plasma donation does help, and we've seen cases of that in the KC Metro and other areas here. So that's my summary, Dr. Stites and colleagues. So that is a bright spot that we'll be starting up with that in our health and environment lab next week. And it'll become more broadly available. I don't know if it's available at KU Hospital and Health System yet. It well may be. I think as we get more broader testing capabilities, it's a positive thing. So that's my comment, Dr. Stites.
Thank you, Dr. Norman, and thanks for joining us. Good luck up on the Hill today, and I hope that you're able to convince everybody of how important contact tracing is.
To that point, and I will be doing that there's a lot of people that in the state of Kansas, including legislators, who feel it's an imposition in people's privacy, and has some deeper and sinister underpinnings, which of course couldn't be further from the truth. We've only been doing this since 1527 with the bubonic plague, and of course in more recent times, smallpox and tuberculosis and HIV and sexually transmitted illnesses, and it's a cornerstone. So
symbolical to me.
I hope to not be frustrated. So I'll go to battle.
All right. Well, good luck, and use your tranquilizers before you go, my friend.
Okay. Thanks, Steve. Bye-bye.
Bye-bye. All right, so I'm sure there'll be a lot of comments about that. I know we'll have some, but first, Dana.
Yeah.
How are we doing today?
We're doing well, and I don't want to jinx it, but I think we're doing very well here at the hospital. 13 patients in the hospital.
Yay, that's a really low number.
So we've actually moved patients to one unit, which is good. We want to keep that number pushing down. 3 still on the ventilator, though. We've had that for a while. We understand that patients with severe illness, critical illness, who go on the ventilator, it usually does take a long time for them to come off the ventilator. So, again, I think we had 15 or 16 yesterday, so we've had a couple discharges. But right now, 13 in the hospital and 3 on the ventilator.
And my concern would be that the numbers across the state continue to rise. We're seeing more and more people, a different patient population to some degree, younger, not as much in the nursing homes. But talk a little bit about that. How long before we know, do you think, if that's going to generate a lot more admissions to the hospital? Because the numbers are kind of going up pretty fast.
Yeah. I think, we had some talks with the modeling yesterday in one of our evening meetings, and we had originally thought, well, maybe 1 to 2 weeks because that's the incubation period. Now we think more is it's probably like the 3 to 4 week range as you have continued growth and spread of the virus, and then the people who are infected, who may or may not be having symptoms, after they have initial symptoms and then develop maybe some of the immune dysregulation, the cytokine storm. So we're actually maybe looking at, with modeling, probably more of the 3 to 4, even 5 week range before we really truly know. Unfortunately, also what we have seen is in studies, a recent study on one of the cruise ships, where they detected infection in over 60%, about 60% of the people. About 80% of those were actually symptom-free. So we are learning more and more about this disease from the original published Chinese experiences. We are seeing more and more people who have the infection but don't necessarily have symptoms. And I think that small confined space of a cruise ship just kind of adds to that point of there are probably a lot of people going around without any symptoms at all, and that's certainly different from what we thought initially.
Yeah, it is an important difference there. So we're going to get into antibody testing more, and I guess one of the questions is going to be when we are going to start it here at KU. So we're joined now by Rick Couldry, who's our Vice President of Ancillary Services. I forgot your full title, Rick, sorry. And generally a good guy.
Big wig.
Somebody I don't have to worry about that has whether he gets a haircut because he's got, well, actually less hair than I do. But Rachel, talk to us a little bit about where we are here at the health system regarding antibody testing.
Right, so we elected to evaluate 3 different antibody testing platforms. That way we can kind of look at what works best for our hospital, what has the best data, and make the best choice for us. And so we started collecting those specimens several weeks ago in preparation. We've started our evaluation this week. We should have most of the data probably by the end of this week. There is some partial data waiting in my inbox this morning that I was very excited to see, and I haven't fully evaluated yet. After we do our data evaluation, we will select our test, work with our vendors, build up all of the IT components so people can order it, we can result it, and then we'll be ready. So we're still a couple weeks out probably from being ready, but we want to do this in a careful and thoughtful way so we get the best test for our lab, for our patients, for our hospital system.
All right, so we're going to get into a conversation now about something that I think it's kind of hard to explain a little bit. And well, you and Dana and Rick, let's take a crack at this so the public understands this and to our listening audience. So one of the things that's really important in testing is that when it's positive, it's really positive, and when it's negative, it's really negative. Talk to us a little bit about what that means in a lab and how it can be confusing and how it can lead to some things you might act on that isn't really true.
Okay, so you're going to make me do math at like 8 o'clock in the morning.
Yes, I am, because I know you're very capable of that, Rachael Liesman.
Right.
But we have to do it in a way that we can all understand, including myself.
Yeah.
I heard Coletree laugh because Coletree and I, we're not going to do the math.
It's because I talked to Rick about this a lot.
I can't do that.
You know, a lot of people are asking, what's the specificity of this test, right?
And what does that mean?
So they want to know, you know, Dr. Norman at the beginning was talking about, does it cross-react with our seasonal coronaviruses? So that is specificity. And the initial testing that was for antibodies had very low specificity. It was in the 80% range, and so that's not very good.
And that's terrible, just to say out there.
It is
that's
quite
terrible in the medical world, because if you
Right.
say, well, I'm going to be right about your diagnosis 80% of the time, how good would you feel about that?
Right.
Hey, listen, I think you have, let's say, cancer. I'm about 80% right.
Right. We did not elect to bring up those particular assays and actively discouraged our providers and our system from using those particular assays. The newest ones have 99% specificity, which sounds really good, right?
That sounds great.
99%
happy
sounds
about that.
awesome.
Yeah, 99% chance the Chiefs win the Super Bowl next year.
Yeah, I'll take that, right?
Yeah,
I'll take those odds.
Yeah.
But in the lab, we also think about another statistic, and that is positive and negative predictive value. So positive predictive value is asking the question, if you get a positive result, how true is it, right? So
How likely is it to be right? If we say that you've got it, it means you've really got it.
Exactly.
Yeah, that's important.
So positive and negative predictive value are really dependent on what the prevalence of your testing population is, right?
Yeah.
So if you test people and 50% of them truly have disease, that's going to impact your positive and negative predictive value.
Because you have a lot better chance of being right when there's a lot of disease
Right.
out there.
Statistically, you've got a lot of positives, so odds are you're going to pick them up, and you're not going to. You're kind of your number of true positives are going to way outweigh your number of false positives.
So they're kind of like saying, if I have a test that gives me the number of good apples in the bag, and half my apples are good, I'm pretty good at that.
Right.
But if I don't have any apples in the bag, what happens?
Right. So if we think about, let's say we have a prevalence of maybe 2 or 3% in Kansas City, which is probably in the right ballpark from what I've seen from modeling. And we want to test just a generic population. So you want to test the people in your business, or you want to test a bunch of college students before they go back or something like that.
Oh, wait, we may be doing that. Go ahead.
Right. So what's going to happen is if you have 100% specificity, you're going to have 100% positive and negative predictive value, right? Like
Which is
just by
awesome.
virtue of the fact that it's 100%. No test has 100% specificity. If somebody tells you a test has 100% specificity or sensitivity, you should probably kick them out of your office. That's just not really possible in the laboratory medicine world. So let's say you drop that.
It's hard to believe that, and no patient ever wants to hear that, but there are, and that's why we have redundant systems in medicine to protect patients, because we
Right.
know we're not 100% on anything.
Right, and we always tell our providers, treat the patient, not the test, right? So if you get a test result and it doesn't make sense, let's talk about it, let's do additional testing, let's figure it out, because we want to be treating patients and their symptoms and not treating a test that we're running in the lab. So back to our math, right? So 99% specificity sounds really great, but in a population where you have 2%, so let's say you test 1,000 people, you get 2% prevalence, you're going to come up with 20 positives, right? Those are your 20 true positives.
You hope, because as long as your test is good.
We're going to work on a super sensitive test.
Yeah,
So
okay.
you're going to catch
So let's catch all of
everybody.
them, all right.
We're going to catch everybody.
All the good apples.
But remember, you have 980 people that are negative, true negative, and because you're at 1,000 people, 2% specificity, and you only have 99% specificity, right? So you're going to end up catching 10 false positives.
Right, so you're saying, I'll get the 20 who were right, but
Right.
I'll also get
You're also
10 who
gonna
I'm
catch
wrong
10 that are
about, so all of a
wrong
sudden,
about.
that doesn't feel good.
Now a third of your positives
Right.
aren't correct, right? And so that's where prevalence has this impact on positive and negative predictive values. So we want to be really careful if we start using these assays, even the assays that perform very, very well on paper, about telling patients, yes, this is a true positive, or about who we select as our patient. We always want to select patients to test that have a probability of being positive. And so we kind of just want to be careful in just blanket using this for patients that have no history of symptoms, and we don't really know what we're going to do with those results. Now, from an epidemiological point of view, we can control that statistically, right? So Dr. Norman's group can apply statistics and say, well, we know some of these are false positives, but that's okay, we can work around that. But for us, when we're talking about individual patients, it's difficult to tell them, well, I don't know, a third of you might be right and a third of you might be wrong, and we're not
That's
sure.
a big number in medicine. That's not too good.
It's significant, and it's significant, when it is put up against that, it's 99% specific number, and so we just need to continue.
Especially
to be careful there.
if we're then saying to people, you have protection against the disease, but we have a good chance of being wrong about that statement. And actually, we may not even be right about whether or not coronavirus antibodies give you protection
Right.
against the disease,
Yeah.
Dr. Hawkinson. So Hawkeye, what do you talk? Let's talk to us about that.
That lends to your point too, so if we do tell people you have protection and they get reinfected, or maybe they were infected for the first time now and that test was actually inaccurate, that has a lot of implications as far as the natural history of the virus goes that we're still trying to look at. So I think those are very
When do we
important.
use the testing? What is the good of antibody testing, given all the numbers that we just walked through? Well done, though, this early in the morning.
I think the best time to use them, as Dr. Liesman had talked about, is in the large seroprevalence studies, looking to see what percentage of the population
Because we're
has
not
been
acting on an
infected.
individual test then to tell
Correct.
somebody to do something.
Right.
Rather, we're trying to study a population as a whole. And that's a really important difference. It's giving us the power of looking at a population versus here, because you have this antibody, you can go out and play in the garden.
Right.
But the reality is that statement probably isn't correct on the basis of antibody testing, which
Correct.
means the infectious disease pillars of wear a mask, wash your hands, don't touch your face, keep 6 feet away, all the,
Yeah,
all the things we
distancing.
preach every day,
It's
we're going
still
to keep
very
preaching
important.
about.
Right.
Okay, so end of sermon, go ahead.
Yeah, absolutely.
really yet.
We hope and we want you to have protection once you've been infected and recovered from COVID-19. We think there is. We just don't know to what level you have protection and really the amount of time. Certainly in the typical coronaviruses, the coronaviruses that cause common cough and cold, there are 4 of them. And we think anywhere from 60 to 90% of people probably have those antibodies. So that's why it's really important to be specific for COVID-19 when you are doing these antibody testing. So anyways, we would hope that once you are reinfected with COVID-19, you would have some level of immunity. We just don't know exactly how much. or for how long. Hopefully at least 3, 6, 9 months. But we've seen in other common coronavirus, the cough and cold coronaviruses, that even infection with the same virus, even like 9 months later, you would still get some mild disease. So that's very important to note as well.
And you may still have the ability to transmit, which is important in the context of the pandemic as well. You know, when we're evaluating these antibody tests, the easiest population to find that we have plasma or serum for are hospitalized patients. So we really have evaluated the performance of this on our sickest patients and on people that have no disease. So there's a gap in our knowledge about people that have mild illness. Do they mount an antibody response? Can we find IgGs with them? And I think we don't fully know that yet, and we're still kind of learning. And it does have implications for reinfection, for transmission, for how well these assays are going to perform and tell you, yes, you were exposed, or no, you were not exposed.
And interestingly, they've also seen in patients who have recovered, haven't mounted that IgG response. So again, that's probably a very small proportion of the population that we know from published studies, but we are still learning more about this every day.
And as we know of many viral diseases, actually, there's a population that may not have a big antibody response,
Right.
but they recover because we have different ways in
Yep.
our immune system to handle disease and infectious disease.
Yeah.
It's not just antibody.
Right.
There are other things that our body
Yeah.
does. In fact, there are a lot of other things our
Yes.
bodies do in order to do it. Again, our body is pretty remarkable. Lots of redundant systems within it. It's amazing how well constructed the human body is. So.
That's an amazing part of the immune system we have to understand, and we hope that when we do have the vaccine, that it elicits not only an antibody response, but also a T and B cell response, and that is our cellular immunity. So that being said, you know, you can continue to wash your hands, social distance. That is not going to reduce your immunity. Keep doing those things. But just as you talked about, we have multiple ways of trying to fight off this virus.
Rick Couldry, as we look at across our large scale, all of our different testing platforms, et cetera, what's the future of testing hold here at our health system?
So, you have Rachel right there with you in the studio, and all of the testing that we've accomplished so far has really been done with her leadership, guidance, and hard work, and is in her section of the lab. So, she's far more of an expert than I am, without question.
Are you getting a haircut? What are you doing right now, Couldry? What are you doing out there?
What do you mean, what am I doing? I'm working at South Lake today, sir.
I'm just messing, Rick Couldry. I'm just messing with you. All right,
Yeah.
let's turn to media and ask if there are questions that they have for us this morning.
Good morning, gentlemen. Thank you for that very valuable information. So I understand that it's going to be a couple of weeks before KU can begin offering it. Is it going to be something like the drive-through testing? Is it going to be more readily available? Is it going to become fairly commonplace, or what are your thoughts on that?
That is a great
question.
Okay, Rachel, any insight? Then I'm going to give it to Dana, and maybe you should give it to me because I suspect that's the one supposed to answer that question. I'm going to try and dodge it.
Yeah, I'm going to try and dodge it too, right? Yeah, I don't know the answer to that.
Yeah.
I either haven't been part of those conversations or I'm not.
Well, I'm going to take it on. Dana, any thoughts from your standpoint?
I think that's difficult. I think that has to be done by an individual provider and the patient. As far as antibody testing goes, I've had friends come up to me because they've had different issues, such as they thought they had COVID toes, so skin manifestations. Other people have had GI or gastrointestinal manifestations. We know that COVID-19 can cause atypical symptoms, so they want to get tested. I think it's important to note that one type of antibody that you start to get and you start to mount is about an average of, most people have it about 5 days. The main one that we test for, however, most of the people develop this antibody, the IgG, by 11 days, and nearly all the people who are going to mount an antibody response will develop it by 14 days. So we have to understand that this is not to acutely diagnose COVID infection, but maybe on down the line, 2 or 3 or 4 weeks later, especially if you want to donate plasma for our plasma trial. But I think it has to be down to the individual provider and the patient themselves to decide Do you need the antibody testing? What will that tell us? And what will we do different if the antibody is positive? Again, because it's not for the acute infection, it's going to be 2, 3, 4 weeks down the line.
So here's the rest of the answer. You've asked a great question, because what you're really asking is how are we going to use the information, and so therefore how are we going to test, and can just anybody get it? I don't think we'll be doing that. I don't think it's going to quite look like a drive-through clinic, at least not yet. And here's why. I'm a fly fisherman, and I think what possibly can antibody testing have to do with fly fishing? So just give me a second here. So when I go down, I've got to figure out what flies I'm going to use to try and catch trout. And when I go down to the water, I look at the water and I see what kind of bugs are on the water. What's the weather like? Where's the sun? What's the water temperature? What's the shade of the water? All these factors figure in to what I'm going to do. I think when you think about antibody testing, it's a lot like that. Antibody testing belongs in the ability of your healthcare provider to help understand what to do best for you. And so it's a piece of information that can help you understand what has happened to you historically, what the diagnosis is, and what should you do. In an acute person who's coming in who has an acute COVID attack, I don't know that it's going to be very helpful, because really the PCR testing is going to give you an answer. On the other hand, if you have a chronic cough after you've been sick from late February, okay, this is what happened to me. That's why I'm going to give this story. So I've had this little bit of a cough since late February, and I thought to myself, I was told the coronavirus, initially we thought it wasn't in Kansas City, in the area, until March. Well, that was wrong. It's probably here in late November, early December. So, question, could it have been that I had coronavirus? I don't know the answer to that question. Could it be helpful to answer? It may be helpful to answer because it will give me an indication, or give a physician an indication, or the team, what the cause of my cough is. And if that is true, then that's going to change how you treat it. So I think that's how we're going to fit antibody testing in. It's going to be another piece of information that we use to determine how to attack the trout, or in this case, how to treat your disease. And I really think that's probably how we'll view it. Now, that's for individuals. The second thing you've heard, and this is important, is it can help give us an understanding of what prevalence is actually going on out in the community. That is not any longer a personal health question, that's a public health question. Or it may give you information as athletes come back to college. Let's touch on that one for just a minute. Because you may have had coronavirus remotely, but the risk of heart irregularities for how your heart beats can go on for several months after coronavirus. And that would mean we might have to treat you differently under athletic activities. For example, you may not be able to play for a while. But so how do you test for that? How do you look for that? Well, an antibody testing might give you one piece of information and then say, now I have to do additional cardiac tests to see if you're having the longer term cardiac issues related to coronavirus that you have to go looking for. So again, an antibody test can give you a piece of information to help you do it. Do I think it's going to be through a drive-through clinic? If with an order from your physician, you might drive through and get the antibody testing. It's a little more difficult, though, than the nasal swab because it does involve blood. It's going to be more like I think it's going to be more like a pinprick, or you have to draw blood.
It'll be a blood draw.
So for us, if it's a blood draw, which will be the best, that is clearly going to be the best testing. If it's a blood draw, that's a little bigger deal. You're going to have to come into the labs. I don't think that's going to be as much as drive-through testing. So I think that there is a way to do the test. I think there is a way to use the information about the test. Mm-hmm. What I don't want people to believe yet is that if they have the antibody, they're protected from getting coronavirus a second time. My guess is that that's true, but I'm not sure that you want to put your entire health in a guess. So I think that's how we'll use it. Did that answer your question?
Yes, that's very helpful. Thank you.
Yeah, and I think,
so will it be something like the flu test where you get it in your physician, but it will be readily available?
It won't be. So it's not a nasal swab; it'll be a blood draw. So that automatically makes it a little bit more difficult, a little bit more invasive. I think it'll be readily available to our patients inside the health system. I think that'll be true, but I think you'll have to have an order to have it drawn.
And some of those influenza tests are simple, what we call point-of-care tests, and those I think are antigen tests most of the time in the physicians' clinics. And I think
if you want to do antibodies to flu or any other virus, that's a blood draw today.
Right.
And then you have to get a lab. That's a little bigger deal. And you have to go to a lab to have that drawn.
But to contrast that with an influenza antibody, we would not really check that for any specific reason. And to contrast the COVID antibody test from another simple antibody test, the chickenpox antibody test.
So varicella.
Varicella, where we know that that confers immunity and safety, and we use that in the healthcare system all the time. We know that you're safe to treat other patients with chickenpox, things that should be contrasted.
That's because we know that's
Right.
true about a varicella antibody.
Right.
We don't know that yet
No.
about a COVID-19 or SARS-CoV-2 antibody. We hope and think it is true, but again, hope and think, it's not the best healthcare policy.
Right.
Other questions? All right, let's switch over to our listening audience. Jill?
All right. Will you please compare the average time people with flu versus people with COVID-19 are on ventilators?
Okay, great question. I can probably deal with some of this.
Go
Yeah,
ahead and
no,
start.
yeah, look
Yeah.
at Stites. He's a lung doctor. Okay, so it's entirely dependent upon how sick you are with any disease. The average time that folks are on ventilators from COVID-19 is probably around 10 to 14 days, and some are on longer than that. Some can be on for weeks, and the problem is the longer you go with COVID-19, the worse that predicts your outcome, which is true about most diseases that land you on a ventilator. Flu tends to not, you can go on the ventilator both because of the flu or because you get a secondary pneumonia. And it's really the secondary pneumonia that gets you into a lot of trouble. And so the problem is that coronavirus is really the primary, it causes inflammation and destruction and scarring in the lung. Influenza tends to cause pneumonia. So as a result, those are two different reasons that you could have to go on a ventilator, and then how you respond is a little different from that. A lot of it depends upon your underlying disease, your age, or other health conditions. In general, I'd say influenza is a little shorter, but it really depends on how you are health-wise to begin with, and both can be very difficult. I'd say that influenza is a little shorter than COVID-19. Again, we're pretty early in the disease process of COVID-19, though.
Can the T cell from the common cold help fight against COVID-19?
All right, Dana.
No. There was a study recently published that showed that maybe there was a little bit of cross-reactivity of some T-cell immunity, but, clinically that is not really relevant. So the short answer to that question is no. We really need the specific T-cell response to COVID-19. And again, we stated that, anywhere from 60 to 90% of people probably have antibodies to the common coronavirus, the 4 types of coronavirus that cause the common cold. Clinically, we haven't seen that there's been any relevant cross-reactivity or immunity to COVID-19 from the other coronaviruses.
Anything else to add around that, Rachel?
No, that covered it. Thank you.
I want to visit my family. Should I be tested? Screened?
But don't
This
leave me
might
this
be
time,
different.
Hawkins. This is your question, brother.
Where are you visiting your family is important. Are you traveling? I think, who has been in your bubble these last few weeks? Have you had symptoms? Again, I know we said that a lot of people can be asymptomatic. I would think the asymptomatic populations would go down as age goes up. I don't think there's a reason to just go get tested or screened for that fact. But again, there are some questions that we would answer or we would ask, and based on those answers. But for the most part, probably I don't know that there's a reason to really go get tested if we are talking about the PCR test. Unless, however, you have been in contact with somebody with known or suspected COVID.
So here's my answer. So my daughter lives in Chicago. She's going to come home this weekend. It's going to be on Sunday. We're very happy about that. We said you have to drive early in the day. Don't be out late at night right now. Got to get home early and get safe. But the question was, so what do we do when she comes home? Now, she's done a good job of sheltering in place. She's been working at home, and she's going to drive. And I said, okay, well, let's come home. And I don't know that she's not been in our bubble, but she's my kid, and so we're going to bring her into the bubble. And then I think next week toward the end of the week, we're all going to go out, our family, and go out in the woods and go camping for a few days, and that's a different kind of bubble still. So, coronavirus is hard, But life is hard, and I think you have to make decisions about life every day, about how you're going to stretch your bubble and how you're not going to stretch your bubble. And I think the key for us is that we're all pretty healthy, and so the risk is, relatively low to us. And I think that'll be the thing. The thing we haven't decided yet is what to do with my 87-year-old mother-in-law, because can she be around my daughter, since my daughter's coming from Chicago and I've driven in, and I'm not sure I know the answer that way. I think the answer will end up being yes, because my daughter's been so darn careful and wears a mask when she ever goes in public and things like that. So I think it's going to be okay.
Yep.
But those are life questions, and you have to just enter your own personal calculus to try and determine the answer, because there's not really a right, nor is there a wrong answer. There's just the answer that allows you to accept the risk that you take from those activities. So for my daughter, it's like, okay, you stop at the gas station, wipe down the pump, wash your hands, don't touch your face, don't be around a lot of people, get back in your car, go. And then you get here and you stop a couple times, fine, but go early in the day, don't be out late, don't put yourself at any increased risk right now. And then get here and get home, and then we'll hang out. And I think that's an okay approach.
Yeah, and I think even in household settings, you can still take as much precautions as possible. You can still do a little bit of physical distancing. If you're going to be out in the woods camping, you'll probably be outside a lot. So there are still little
it's pretty
things
good
you can
social
do.
distancing, actually,
Right.
as it turns out.
Getting away from people and wiping down surfaces, continuing to wash your hands frequently. I think doing those remedial things will continue to reduce your risk of getting it and having it.
What are the risks of contracting the virus at a drive-through facility? Could I contract it from close contact with one of the testers?
Excellent question. Man, do we work hard at that, Dana, to make sure that you don't. So talk a little bit about some of our infection control precautions and what we've done to make sure people stay safe. And by the way, those are also the things we're doing inside the health system. You come into an ambulatory care visit, it does not look like the ambulatory care visit you once knew.
Yeah, absolutely. So for our employees, we take utmost in care to protect our other employees and protect our patients and whoever, especially if you're in a drive-through clinic, you may be having somebody else with you in the car. The answer to that, I'm going to say, is no. We have everybody, our employees who are doing the screening, who are using the NP swabs, are dressed in appropriate PPE. They have gowns, gloves, they have masks and face shield as well. So the quick answer to that is no, you won't have to be worried about getting it from going to the drive-through clinic.
It's really safe, and we work hard at that. And we work hard at maintaining safety in our lab personnel, too. Talk a little bit about that, Rachel. How do you keep your team safe?
Yeah, of course. We're kind of doing the same practices that we've been doing always, because we're constantly dealing with infectious organisms. We get tuberculosis in our lab. We get all sorts of kind of nasty stuff.
And when you
in
say
our
get,
lab.
you mean you don't need to get it personally, but you get it. We had samples
As in
and
the specimens come from patients, but we grow it to really high levels, and so we are always thinking about how we keep our staff safe. One of the things that we did fairly early on is we did universal masking in the lab pretty early, a couple weeks before the health system did, because we work in such close contact. We don't have a lot of space in the lab. We've got a lot of people in there doing a lot of work. And so we wanted to make sure, since we couldn't socially distance, that we are mitigating just that risk of somebody bringing it in from the outside. So we've been universally masking in the lab for quite a while at this point. And then anytime we're working with specimens, we work what's called a biosafety hood or a biosafety cabinet. So this is a cabinet that has airflow, and it essentially keeps any aerosols or anything from that specimen inside of the cabinet. Your face, your body, and everything are on the outside. We use those really routinely. Our staff are all trained on how to use those appropriately. And so that is one of the cautions that we take. And then we do what everybody else does. We wash our hands. We're careful about trying to social distance as much as possible, wiping everything down and cleaning the lab as well. So we've been thinking about safety since we first talked about bringing these specimens into the lab. We talk about it a lot, and I'm very confident that we've got our staff good and safe.
And Rick, we've done this throughout the health system as well. In our outpatient pharmacy, I know that could be a concern for somebody if they have to come in and get their medications or things. But I think your team has worked really hard to make sure that that aspect of our patient care organization is really safe too. Talk a little bit about that.
Yeah, absolutely. It's the same thing. We've worked really hard to actually sign patients up for our home delivery service, which is really popular. And so that's the best way. Is like you don't have to come in, but you can still get prescriptions usually delivered within 24 hours when you call us. And then all the same controls that you and Dana and Rachel have talked about this morning for our staff who are working together with universal masking and physical distancing. So we've applied that really actually in all of our areas in the ambulatory space for radiology areas as well. So if you have a radiology visit, we're going to have the same kind of controls in place. So there's no real congregation anywhere to wait or anything like that. So it's really throughout our entire health system, we've worked to maintain safety for our patients as they come and get the care that they need.
Yeah, and I think that's just so incredibly important to do all those things. So, okay.
My husband tested positive last Saturday. No obvious symptoms. How long do we need to quarantine?
Oh, quarantine and the asymptomatic carrier. All right, Dana.
Well, you would essentially...
Or pre-symptomatic.
Yeah, maybe he'll develop symptoms. The quarantine would still be essentially, 14 days. Yeah, I guess it depends where you live too. I'm going off the KDHE, the Kansas Department of Health and Environment, recommendations. Those are somewhat similar and in line to the CDC guidelines as well. So it's going to be anywhere from 10 to 14 days, basically, with whatever reference you're using. And if you're in Missouri, I'm not sure. I haven't reviewed any of Missouri's isolation quarantine.
So really, it is a 14-day quarantine. You say in some areas. Are there other areas in the country that are doing a shorter quarantine?
Some areas are doing a shorter quarantine for various reasons. Again, we have to also look at what populations are we talking about. Some things such as healthcare systems will maybe doing a shorter quarantine for their workers who have been exposed, but because of a worker crunch or workforce crunch, they may be doing a shorter quarantine. But in general, I think the safest bet is probably 14 days.
Okay.
And I think this is the same question, but I think they're asking, I'm home, I'm quarantined, I don't have any symptoms. How long am I contagious to other people?
So
after the quarantine lifts?
Here's the thing, and I think what is the heart of both of these questions is that they don't have symptoms, so they don't feel sick.
Yeah.
Yet, panel of experts, they think they can still spread the disease.
Yeah. There was one of the recent studies, and it's eluding me right now, but what they found was that, in fact, when they talked about asymptomatic people, the majority of those were lower age, so the median age was 37 years old compared to people who are symptomatic. Median age was like 56.
My age, right? Yeah, okay, that's what I thought.
It's close.
Yeah,
40.
that's what I'm thinking.
And then also, women tended to have a little bit more mild predominance of being asymptomatic compared to men as well. So what they could find is that you probably are going to have less shedding or a shorter time period of shedding. But again, this is just one study, and guidelines aren't made from that. But in general, I think, again, continuing the 14-day based on what we know and the incubation period, and that people can develop symptoms at 14 days or sometimes even longer, the 14-day is probably the safest.
Time for one more question, so we do our wrap-up. Anything else, Jill?
Yeah, there's one that's all you.
Awesome.
All right. My husband had an episode in late March, unable to take a deep breath. That lasted a couple of weeks. He went to the emergency department and had testing done, which was okay. His doctor wants him to see a pulmonologist, but should he just get an antibody test instead? He didn't have any other symptoms.
Yeah, I think in a situation like that where you're still having difficulty breathing, an antibody test may be helpful to give you an answer, but you still have trouble breathing, and the antibody test isn't going to make you better. So I think the answer to that is yes, people need to see somebody if they're short of breath. That's kind of what the thing is, that whole thing about I can't breathe. That we talked about that the other day. That's an alarming finding, and you want to go get help for that. And I mean that in all aspects of our lives right now. So, well, let's wrap up today and just see any final thoughts or parting wisdom. Let's start with Rick Couldry. Rick, I love to mess with you, and I'm so glad that you're good with that because that's. But you give it right back.
You bet, because I was just going to say, come on, do you think I have any wisdom to share at all?
You have a lot of wisdom, brother.
No, sir. No, the only thing that I would say is I really appreciated the conversation today, and with Rachel walking through the math. She's done that for me a couple of times. So anything that I've ever said that sounded really smart around testing, you can guarantee that she was the source. She's done a really good job teaching me a few things so that I can help be a good representative of the health system in the lab regarding testing. And, I know we had that one question about is antibody testing going to be widely available? From a capacity perspective, it is a little easier to process that test. But I think that the important questions are really asked are when and why, and do we need to do that, and whether we actually need to put people through that or not. Are we going to get something valuable for it? But, that's kind of my recap.
And I'll just say, you're a smart guy. Rachel's really smart. I'm same situation. I've got a really smart nurse I've worked with for 16 years, Joyce, and thank goodness, because sometimes I'm not always as clued in. So it's important to have people around you, Rachel, who are really smart and can explain things like sensitivity and specificity and positive and negative predictive value. Well done this morning. Final thoughts?
I think that we just need to remember that our PCR test is our diagnostic test, and it's very good, and it's kind of fallen off the conversation, but really we need to be doing PCR tests on people and doing contact tracing. And where the antibody test really falls, I think, still is up in the air. It's probably got a niche in some specific scenarios. But we just want to worry and take care not to kind of overuse this resource. And it's not really going to answer a lot of the questions that I think people have. And so we just need to think very carefully about that.
Yeah, Dana.
Yeah, as we move closer into the weekend now and into the summer, we have seen that there have been stories of spread of coronavirus from the Lake of the Ozarks. We know from at least one published report that we have someone who went to the protests and got coronavirus. It is out there. It continues to go down to personal responsibility and trying to mitigate all of these risks as much as possible and decrease your risk of COVID-19. And that is, wearing a mask, social distancing, physical distancing as much as possible, and hand hygiene, frequent and adequate hand hygiene.
You stole my line there. I think that's exactly what I was going to say. I was going to talk about all the pillars of infection control again. Instead, I'll just mention that tomorrow, Danielle Johnson, who's a Ph.D. psychologist, is going to be here with us to talk about the emotional and mental health toll on our population that is most vulnerable to COVID-19. We'll be especially looking at some of the racial disparities around that, because I can't breathe means a lot in a lot of ways right now. So we may also be talking about an update on our visitation policy as the health system begins to think about what does it mean to allow people back inside. In the meantime, we hope that you stay inside as best you can, stay safe, stay sheltered, and remember, there's still no place like home. We'll see you tomorrow.